Yeah, I'm the guy who, excuse me, I'm the guy who's going to stand between you and your break. So I'm going to move away from zebras and get into softball. So uh, I can guarantee you the most science you're going to see is the helix on my slide. So shouldn't be. And this I'm going to move to talk about the provider's perspective on rare disease. I'm an internist, and this rare disease business was entirely new to me from where I was coming from. I first want to thank, Oslim for inviting me out. She was one of the inspirations for me to get into the business of rare disease. So I'll tell you a little about it. And as I said, the science is pretty soft here, so you don't need to worry too much. What we're going to do is just talk, identify some of the challenges of rare diseases for primary providers and some of the shifting paradigms in how we manage our rare disease. And I'll give you a little narrative of a model of care for Fabry's that we set up and talk about some perspectives for the future. Keep in mind, these are changing times, especially if you're a primary care physician. Your reimbursement models are changing, your paid for performance is around, the demands to see more patients in a short period of time. It's a hectic place for primary providers. So needless to say, for many providers, rare disease, it's no ordinary Joe diabetes. And I thought I'll put that slide since I'm this close to Washington, D.C. I'm sure you guys have seen some of this before. Well, what are the primary, management strategies that has historically existed for rare disease in my times as a resident and so forth? Most of rare disease were done at major medical centers. Some were done, spattering few were probably done in community teaching hospitals. And even fewer were really done in the primary care offices, with obviously some support from the specialty areas in those major medical centers. So, some of the paradigm shift, and I'm going to kind of try to move on as fast as I can go through here. These were the change in paradigms. These were done in major medical centers, as I said. And now we have a shift in terms of where most care is moving to the local market, where you're seeing localized care. So how do we approach this, and how are we going to make a difference in terms of how we care for those patients? Obviously, we're going to have to start thinking out of the box. So this is a narrative of one of the approaches that we used. I own and operate an infusion center that we started in 2004. We try to provide really, high quality care, oftentimes for very expensive drugs. We stay away from oncology because it's an oncologist purview. We do convenient care. We provide infusion 7 days a week, so 365 days. We have 3 extended days. We do weekend coverage. And we kind of create a really good atmosphere where patients can be cared for. One of the things that we do have, though, is that we have the ability to actually see patients more often than their primary care providers, and we see them more often than the specialty providers who are sending their patients to us. So we are kind of in a good position to do a few things. These are some of the disease entities that we care about, and we just kind of have some of those. Some of the disease entities were talked about earlier. And these are some of the drugs that we do. And so let's just give a little part of what our history with rare disease. And if you look on that slide from 2006, we kind of ran into this by accident. Somebody who was at a center, acute rehab center, Mary Freeman, had called us and said, we had these, Pompe patients, and they were referred to us, and we just couldn't find places to get treatment. Of course, most of the hospitals in West Michigan wasn't prepared to actually start these kinds of expensive treatments. And we said, okay, we'll try. I didn't know much about Pompe, so I started learning a lot about it, and we started in 2006. And then in 2007, we did 6 patients on the MTAP. By 2008, we had our first Gaucher patients that we treated. And then in 2009, we started doing some Fabry's and some of the Fabry's registry. In 2010, we had enrolled 11 patients in the Repligo study. So somewhere around 2004, 2006, I met Oslim, and we were talking at World about this group of patients that we have, and we decided, well, how can we really create something that looks different for them? So what we did, first with the myozyme infusion for Pompe, we kind of worked with this center, and we kind of made the patients, kind of the center, and And at Infusion Associates, we kind of facilitated these patients that were coming from all over the state. And, we provided treatment for them, and it worked to some degree. But we realized there are some issues. So as we kind of moved into the Fabry world, we kind of realized there were some, barriers that really limited many patients' ability to find good care in the settings where they were. Many of the patients were traveling over 150 miles from their home to actually get treatment. And sometimes they had to make additional travel to actually see these providers that were coming from those major medical research centers. Now, as you know, there are a lot of declining resources, and the cost structures and resource management in many major medical centers are changing. Grants and stuff as we used to have before doesn't exist. And there are a lot of restructuring in these places. I was talking to a friend from Iowa. He was in one division. His division was changed to a totally different division. Obviously the bureaucracy has led to a lot of problems. Primary care provider offices and specialty offices now are burdened, and some of the community hospitals are burdened to start picking up some of the slack for some of their care. And it's not manageable in most circumstances. Most of our community hospitals don't want to really get started taking care of these patients. They're very expensive, and once you do, you can't really get out of it. So they're very reluctant, and obviously, haven't really stepped up to do that. So for many patients, they are quite frustrated, and they have kind of fell through the cracks. So we came up with the idea. Well, I'm not an expert like many other people here, but we came up with the idea. Why don't we just create a center, for Fabry's, where we can really, manage these patients in totality. So, not knowing much about this disease, I started going to conferences. I started meeting people who are experts in the field, and started getting some, ideas and how to overcome some of the natural barriers that exist for many of those patients. So, what we decided to do was to become a treatment center. And what did we want to, put in our treatment center? So, essentially, what we have is a clinic within a clinic at our center where we do treatment, but we also do disease management. We do registries. We also, and I'll talk a little more about that, we have kind of made ourselves a surrogate of the patient-centered home model. I'm sure many of you know what that is. The concept of really caring for patients where they are quarterbacked by their primary care providers works for diabetes and for hypertension, high cholesterol, and so forth. But when it comes to rare disease, obviously, the strain on these practices, the ability to really have a model that really look at that is very, very difficult. So we felt that we needed to actually fit some way in how we do that. Well, to do so, most of the modeling of the payment structures from the payers doesn't allow you to really become a patient-centered home model unless you actually owns these patients at the primary care level. The other thing that we did, we figured we need to get patients into clinical trial, and we needed to also be a repository of data so that as we manage patients, through the different phases of their clinical journey, we can really provide and keep some of that information. We also wanted to facilitate some of the support group functions, which have been really instrumental in terms of how we have been able to really move. So this is kind of what the schematic of what we look like. We're an infusion center, and we do treatment, but we also, take the purview of everything that can happen in the life of many of these patients with rare disease. So many times these patients, if they get hospitalized for something, we're there. We provide some of the consultant services so we can make sure that some of the supportive services and some of the clinical issues that may arise in that hospitalization, we can be there. If they have elective surgery, we actually do the clearance for these patients so they can actually do so. We also have great communication that we have between the primary care physician and ourselves. Not only after every treatment, they actually get communication for us, but twice a year we actually communicate with them by getting some of the information they don't usually have. For the subspecialty side, what we do is that we do something that's a little different. We actually manage the subspecialty part for the primary care physician. It's a very difficult thing for primary care physician to set up 5 different subspecialty visits for these patients, and how to really have, and how to get patients to really have, good care. We felt that we need to take that burden on. So I did something that was kind of novel. I went to some of the payers and I said, hey, can we do something different in terms of how we get paid? And we set up a structure in where, obviously they can't, in these day and age, they can't create new codes for you because they're very difficult. But we were able to, get ourselves designated as a special PCMH home for these patients. And through some uplifts in payments and so forth, we were able to really get a management fee for really taking care of those patients. So one of the things that we also realized was that for these rare disease, many of these patients, were burdened by cost issues. So we decided to, have something that we felt was already in the construct of what we do. At our center, we say we want to have a good experience from the time you call the office to the last bill that you get. As a matter of fact, our billing office, we have this issue. The AAA works there too. You got to have quality, you got to have patient satisfaction, and obviously you have to have decreased costs. So we go the extra mile to really help patients work through their billing issues. When there is no money, we actually work with some of the drug companies and the foundations to really cover their copay. But we also do a variety of other things that makes the billing experience just as good as the experience that they have in the care for the patient. So it's really a complete and kind of a surrounding care. And I talked a little about this slide here where I said for the subspecialty guys, I'll probably just want to say one thing about the slide that we do. In many of the traditional centers where you treat rare disease, many of the subspecialty physicians are physicians who have a love for that. They had funding, a grant to take care of those patients. In the setting where we see these patients, we can't find these subspecialty guys who have that kind of love. Or if they do, they really can't afford it. They belong to a hospital group who will say, we really don't have the money to do this. So what we have done is that we have created what we call a template model. We have built these templates. So if you go to a neurologist or you go to a GI guy, you go to an ophthalmologist, there's a template that they know what they need to do yearly, when they need to do it and so forth, and what they need to report back to us. We act as that repository of information. So we do what we call kind of a bidirectional flow, that we get most of that information, we set up the appointments, we make sure the patients can go there, we help in negotiating the support for them so they can get there. We keep the information, and then we have that information kind of bidirectional flow. As I told you, we do that twice a year. We send information to the primary care physician. And we also do that between the subspecialty group and ourselves. Presently, I'm developing something that's newer where we are working with the payer to actually come into a site and look at population data so they can look at the triple aim and see how we are being cost effective with comparison cost to hospitalization and when they are done elsewhere. We also having them look at our patient satisfaction scores, and we also having them look at some of the functional benefits that these patients have by developing a couple apps that we are getting to do that. So, this is kind of where we are. This is a timeline. It's 2014, and this is what our numbers look like for Fabry's. We have a total of 26 patients. There are 17 female, 9 males. The adults, there are 21 total adults, 14 and 7 of females and males respectively. We have, on registry, we have 20 patients. Those that are treated with ERTs, you can see there are 14 of those. Patients who are treated with study drugs, there are 4 of those, 2 males and 2 females, and then some that are untreated. We have 6 other folks who are really young, who are kind of in the pipeline for us, and actually we have 2 that we are getting on board pretty soon here. So it's kind of a novel and different way of looking at how we can take what traditionally used to exist in a major medical center, where we can make it local care, doing it different. We are constantly trying to think out of the box how to do that. We have, within our infusion center, this is the 3rd clinic within a clinic that we have done to really focus in terms of creating the surrogate of the patient-centered home model. So, thank you very much, and hopefully I can answer some questions later about it.